Our 30-minute clock has just started. I'd like to welcome everybody to the burn case presentation. I'm Tina Palmieri. I'm a burn surgeon and intensivist in Northern California. I work at Shriners Hospitals for Children as well as the University of California, Davis. So I take care of both adults and children with burns. And my
Matthieu Legrand. I work at UCSF, California too. I used to work with adult burn patients and doing academic work on burn patients. Yeah.
And this case presentation is for you. How many people here are interested in starting from the beginning from a case and just kind of having us work through it? All right. How many people want advanced, late, intensive care stuff? Okay. We'll get a little bit of that in. How's that sound? And we'll have some controversy because we've got planned. We really do like each other. And we have a little controversy planned to see how things go today. Because whenever you treat a person with burns, there's lots of opinions, and as you've probably noticed, not lots of data. So oftentimes there are conflicts, but it's good to talk those out. So what we thought we'd do is start with some overall of the priorities. We'll talk about some priorities in burn management, and let's get started. This is a true case, one of the first cases I had to take care of when I first became an attending. And it was a 32-year-old man and his 2-year-old son were trying to repair a propane heater. So a heater in the house. It happens every winter. And of course, the little 2-year-old's following dad, like 2-year-olds do, and was a little bit close, and it explodes. They're both trapped in the building for 10 minutes before they're rescued by firefighters. They're awake. But they're combative and they have burns on their chest and arms. Where do you start? Airway, right? Yeah, this, like I said, very simple stuff. You're going to worry first about the airway, the breathing, and the circulation. And I'm going to take a detour here. There's some new data out about burn first aid, and it comes out of Australia. And this actually has become the standard of care in Australia, that they irrigate burns for 20 minutes with cool running water, and it decreases burn depth and extent. So I encourage people to look at that literature that's coming out, and it's something new in first aid in burns. We've been trying it in our emergency room, and it's worked very well. Now, having said that, one must still be alert to the airway, the breathing, and the circulation. And in burns, it's going to be different for several reasons. Actually, the leading cause of death in burns is people die in the house from the smoke, and they die from hypoxia. And respiratory failure remains the leading cause of death in burn patients overall, although infection is also a major cause. And note that pneumonia is a big issue in the ICU. So if you're taking care of a burn patient in the ICU, I'd be really surprised if they don't get pneumonia. It's between 15 and 20%. So now our patients are both awake, they're confused, they're breathing at about 20 breaths per minute, so not too bad. The pulse oximetry has a saturation of 100%, but they're both confused. Why is that? I'm sorry? Carbon monoxide. What else could it be? Yeah, it could be explosion. They kind of got a traumatic brain injury. Could be hypoxia. So when a fire gets into a room, it actually consumes all the oxygen. And if you actually leave a fire in a room with the door closed and no exit, it will put itself out when it consumes all the oxygen in the room. So hypoxia is actually one of the leading causes. So what are you going to do to treat them initially? You're going to give them oxygen? Yeah, you can't go wrong with that. All right, so the airway injury after burns is actually divided into several different types. First is hypoxia, which we talked about a little bit. The second is carbon monoxide toxicity, and we're going to add something a little to that. The third is airway obstruction, and the fourth is smoke inhalation injury, the type that most people actually think is what happens, but all four of these are components of the airway injury after burn, and they have slightly different treatments. We talked about hypoxia already. Other components get absorbed as well. We've actually measured toxic products of combustion and burn patient blood from the things that get absorbed. Think when plastics burn. Think when rug carpets burn and wool burns, you get formaldehyde. All that is generated and inhaled. And what's inhaled exacerbates the injury. So carbon monoxide toxicity, as someone mentioned, it is more, its affinity for oxygen is 250%, or hemoglobin is 250 times that of oxygen. So it literally knocks oxygen off the hemoglobin molecule and starves the patient from oxygen. And you don't have to yield very much. Now, I'm not an anesthesiologist, sir, but you are. But 0.1% of carbon monoxide yields a carboxyhemoglobin level of 50%, which is not a lot of gas. So that it is an issue. And it also shifts your oxygen hemoglobin dissociation curve to the left. This bottom factor is very important in that it explains why patients with inhalation injury have a severe acidosis at the onset of injury. The cytochrome oxidase enzyme system is responsible for maintaining your acid-base status. And if that gets knocked out, which it does oftentimes in inhalation injury, it will yield a profound acidosis just from the carbon monoxide toxicity. It doesn't have to be anything else. These are the common symptoms, and notice that it's progressive cerebral dysfunction. I like to say that truck drivers in California who are subjected to smog and smoke cigarettes in their truck, their carboxyhemoglobins are about 10, which explains why they drive so crazy, because they're always a little bit out there. Okay. Normally, carbon monoxide toxicity is red nose and cheeks, but if you're hypoxic, you are not going to be red. You are going to be purple or ashen. And carbon monoxide toxicity is associated with inhalation injury. And one important fact, pulse oximetry is not accurate in carbon monoxide toxicity. It's because carboxyhemoglobin refracts light exactly the same as oxygenated hemoglobin. So unless you have a very specific co-oximetry on your pulse oximeter, you cannot tell the difference. My hospital, and I do burns for a living, my hospital has not invested in this pulse oximeter because it's just too expensive. So I doubt that most of your hospitals will have invested in that. So always check a blood gas with co-oximetry if you're concerned about a patient having carbon monoxide toxicity. And the half-life depends on how much oxygen you inhaled. The higher the oxygen content, the faster you get rid of it. The treatment is you treat it until carboxyhemoglobin is less than 10%. By a face mask if they're awake, intubated if they're not. Hyperbaric oxygen reduces the half-life to 30 minutes. If someone's intubated and you put them on an FiO2 of 100%, that half-life is 45 minutes. So it's hard for me to justify sending someone to a chamber across town because by the time I get them there, it's already done its work. Now, before we go to the patients, Dr. Legrand, would you tell us something about cyanide toxicity, which has been popularized, particularly in France, not so much in the United States for some reasons we'll discuss back and forth.
So, can you hear me? Turn on? Okay, thank you. All suspect cyanide toxicity in this patient and try to give maybe an antidote for cyanide. All. Raise your hand. So what would you give? Why and what will you do? Yes. So, yeah. Among the different toxic in smoke inhalation injury, there is always a fear of severe cyanide intoxication, and we know cyanide is a very potent mitochondrial poison. Okay, it can be lethal, very rapidly lethal when it's high concentration. The thing is when you have a sufficient suspicion of cyanide toxicity. And that's true in France. We tend to give, not only in France, but in Europe, and I would say even more and more in the US probably, including, and that we can talk about that later, not only in burn patient, but for resuscitation of septic shock, we tend to give a cyanokite, hydroxycobalamin. Hydroxycobalamin binds, scavenge actually the cyanide, and the cyanocobalamin, which the combination of cyanide and hydroxycobalamin is being eliminated in the urine afterwards. The thing is that we observe severe renal toxicity with cyanokite. Hydroxycobalamin with oxalate nephropathy. And when we measure oxalate in the urine of patients who receive hydroxycobalamin, there is always some urine oxalate compounds. Okay, some of them will develop acute kidney injury because the pathophysiology is complex, but it could be a concern for what we call crystal nephropathy and oxalate nephropathy in patients receiving hydroxycobalamin. So you mentioned, yeah, you have a suspicion, could have a suspicion, but I will have to have more information before giving. I'm not saying we shouldn't give it. I think we should give it to the right patient, because if you give it to the patient who might not have a severe cyanide toxicity, you might expose the patient to the severe side effect and not the benefit. So what will be the trigger? You have an idea? What should be the trigger for you to give cyanokite or hydroxycobalamin? I know you are. How much? How high? Yeah, I would say yeah. So you mentioned closed smoke inhalation injury, so being trapped in a closed space. That's the first point. You need to be entrapped in a closed a space to be exposed to the sufficient amount of cyanide. Then you need to have some degree of organ dysfunction, because having cyanide toxicity implies that you have a mitochondrial toxicity, and you have to have some degree of cardiovascular dysfunction, hypertension, altered mental status, and so cardiac arrest should be the last presentation, or that will be too late. But at least some degree of instability and altered mental status, and then a good biomarker for a mitochondrial dysfunction. It's the serum lactate, and the lactate is very high, at least above 8 or 10, before having a strong suspicion of severe cyanide toxicity. So the three combined, yeah, you have a strong suspicion of cyanide toxicity. Lower, I would say it's a kind of case-to-case basis, because once again, you might have severe renal toxicity from the hydroxycobalamin. That's my opinion. But
Okay, so severe persistent acidosis, as measured by lactate, they have to have the right history. If they were outside, just hanging out and not in an inhaled room, and hemodynamic instability. Now, things you have to know if you do give hydroxycobalamin, it's not a free lunch. Okay? It will immediately turn the urine red or purple. It will scare your nursing staff almost immediately. And your surgeon will think there's hemoglobinuria the minute they see it. So you have to make sure that the surgeon knows about it and that they have a clue about what hydroxycobalamin does. If you do have to dialyze the patient, you have to be careful on which dialysis machine you use. If you use a colorimetric machine, it will not work. You literally will not be able to dialyze in that case. Now, we figured that out. You can get around all that. The third thing, and then there's a great paper on this in Pathology Laboratory Medicine. Okay, why I would be reading that is because I'm interested in this topic. It alters any colorimetric laboratory test. So it alters hemoglobin, it alters platelets, it alters liver function tests, it alters coagulation parameters. So you have to tell your blood bank and your pathologist that those tests are altered. And that's out there in the literature, and if anyone's interested, I'm happy to send you the reference, because if you're going to use it and there's a reason to use it, you should be informed on how to use it. Okay? But it is something that I think we must consider anytime someone is trapped in that building with an acidosis and hemodynamic instability with mental status changes.
Do you know what is hydroxycobalamin a scavenger of as well? You know, why? Have you heard the use of hydroxycobalamin in septic shock? No? That's good. Perfect. I've been a growing interest in using hydroxycobalamin in refractory septic shock because it's a very potent scavenger of nitric oxide. So it's a potent, you see the blood pressure going up when you give hydroxycobalamin for sure, because it could be treating the cyanide. That would be the good option, the good scenario. But it's also a very potent scavenger of nitric oxide, which is potent vasodilator we can find in septic shock. The problem that unselective inhibition of nitric oxide actually has been associated with kind of worse outcome in septic shock. So I will be kind of, in brackets, be very careful with the use of hydroxycobalamin in patients who have no or low suspicion of cyanide toxicity, both because it could be toxic through the nitric oxide scavenging effect, but also through the renal toxicity.
Yeah, and you will be seeing more sepsis papers on this because the nitric oxide inhibition is definitely coming out there. Okay, let's come back to the patients. You put them both on 100% oxygen. The carboxyhemoglobin is 15% in dad, 25% in the child. They have similar burns. The child becomes stridorous and starts using his abdominal muscles to breathe as opposed to dad. Why is that? They're burned in the same spots. Any idea? I'm sorry? Yeah, I think that's what you're saying. Yeah. Yeah, the airway in the child is smaller. And, oh, I forgot. Burn presentation, there's gross pictures. I apologize. So, this brings up type 2 inhalation injury, that caused by obstruction from edema. The room, when there's a fire in it, heats up to about 150 degrees Celsius. Airway obstruction generally takes 12 to 18 hours. And in low resuscitations, it can take a little longer. If there is a cutaneous burn, the injury will be magnified, so they will get swollen faster. And there is an anatomic distortion of the head and neck. It can be very, very challenging to intubate these adults and children. And if you'll note, nobody's going to argue with this child here. He's got a pretty bad burn. By the way, he did fine. The only pictures I show of people who survived. This child has a burn, and note that there's a tube that's secured in a different way. Tape will not work on a wet face. So traditional methods of securing your tubes and securing your lines can't be used in burns. You have to start thinking forwardly. How is it diagnosed? History is most important, and following along. Hoarseness and stridor is a big sign of it, as is missing facial hair. If you do laryngoscopy to check out if that airway is bad, make sure you have an endotracheal tube and suction ready, because if the airway is small, it may be your only time. And this obviously is an airway that had a little bit of a problem. And intubation should happen for all the usual intensive care things, in addition to a massive burn, which is generally about 40% because the whole body develops anasarca and prolonged transport. How many people were in the resuscitation session this morning? Anyone? They talked a lot about patients who are swollen but hypovolemic. And this is a classic example. Burn patients will get very swollen, but intravascularly they lack fluid. So it's a case where edema does not tell you what's going on. Other special considerations, especially with children. Children have a higher incidence of inhalation injury because they hide. Especially if they caused the fire, they'll go hide under the bed. All the targets are smaller. Their lungs are continuing to develop until they're about 8 years old, and so their bronchioles don't finish. The good news is that children can compensate, and they will breathe faster. My personal best is a child who came in breathing 90 times per minute. Now, it went from 90 to 0 in about a minute and a half. He just literally had come through into our unit. So, but when they fail quickly. It's very difficult to assess mental status, and because they don't cooperate. And that if you tell an adult to keep a tube in, They generally will unless they're doing drugs or something. But if you tell a child to leave the tube alone, what's the first thing they're going to do? They're going for it. Okay, so you want to make sure that you keep that going. Some anatomic differences: they have a shorter trachea, a smaller airway. The vocal cords are more anterior. Their tongues and their tonsils are larger, and the posterior pharynx is very right-angled. Also in children, the cricoid is the narrowest portion of their airway. So in children, you get the most experienced person to intubate them if they need intubation, because that they will be the most difficult. And edema, as we mentioned, is also a bigger problem. And this line right here highlights what you all recognized, is that the smaller diameter airway is decreased by 75% in a child with a 1 millimeter difference. And endotracheal tube size and type, people say use the fifth finger. I don't know about you, but looking at somebody's finger and figuring out what size endotracheal tube that is just doesn't work for me. This is one where I actually memorized that. Okay. This tube is secured in 2 different planes. And I know the pictures can be disturbing, but notice the swelling. And this actually works for adults very well as well. This face is wet, it's swollen, and it's going to keep swelling. So you cannot use a fixed tie on the head to hold the tube in, because you're going to have to adjust it as the swelling goes up and the swelling goes down. This is a mechanism, it's almost like a bridle, where one goes across underneath, and it's just the twill tie that you use to hold a tracheostomy in, and this is suction tubing. And so it keeps the tie from cutting the corner of the mouth. And then we put a second piece over the top so that the tube can't slide down and out. It holds it in place. And it's adjustable, and usually we use a trach tie for that. But this, we found, is very helpful in anybody who develops edema. It doesn't have to be a burn patient. Anyone who develops edema, tape is not useful. I'm sorry?
It just to protect the tie between so the tie goes in the tube.
Yeah.
And then you have a hole here to maintain the ET tube. It's just to protect the skin from the tie.
Mm-hmm. And note, if this tube came out, how many of you would think about successful intubation is not going to happen. This is a surgical airway if this tube comes out. So however you secure it, it must be very secure and monitored very, very closely. Okay, adjuncts to intubation. Children cry, they swallow air, their stomachs get huge. Should always empty their stomach with a nasogastric tube. Although the nasal tracheal route is better tolerated, you should intubate with what you're good at. If you are good at oral intubation, use oral, because you only get one chance, and this is not the time to experiment, especially in children. We talked about the tape, and this last line sounds very obvious. You should get a chest x-ray after you intubate. Of course you do. There was actually a study that looked at an x-rays done after intubation in children in an emergency department. 40% were in the wrong place, and only 40% of those 40% were fixed. So when you get it, look at it. Okay. Keeping the head of bed elevated is important because children can also develop cerebral edema just from the burn injury and the loss of the blood-brain barrier. Keep that head of bed elevated. And asthma is an increasing problem, and with inhalation injury especially, it acts a lot like asthma. And bronchodilators can be very helpful, and early tracheostomy may be beneficial. Okay. So, respiratory burns. This is the one everyone thinks of what a burn is. And this is from the smoke. It's from atelectasis, and overall mortality is 5 to 8%. What's the mortality of cardio, like if you have an open heart surgery? About 3%. So having an inhalation injury has a higher mortality than having open heart surgery. This is a serious business. That's why we spend time on it. And this is all the stuff that happens. Casts develop, there's inflammatory cell migration, procoagulants, and the gland secretes. Obviously, this is someone who didn't do well, but you can see the secretions building up in that airway. And this is despite protective lung ventilation, despite all the maneuvers that we've tried. Oh my. That's probably not what we wanted to do. Let's get to resuscitation.
Any question in the meantime? Who among you would treat burn patients on a regular basis? 2, 3, 4, yeah.
All right, so for resuscitation, we're going to cut to it. That was very interesting going. The patients who need resuscitation formulas are those with a burn over 20%. Right? If they're 5%, there's no point doing a resuscitation formula. No one ever tells you when to use the formula. They just tell you to use the formula. So this is what we do. Now, in the pre-hospital, this is what our paramedics use in the United States because they don't have the luxury of having a formal calculation of the burn size. So what we've done is we've told them, we want you to run the fluid at this rate until you get to the hospital. And then we adjust it. So we found this to be really helpful in getting more fluid started if the burn is more than 20%. So this is kind of the algorithm that gets used. And this is the currently recommended, was changed in the last year, resuscitation fluid rate for a burn injury. And like all things in the US, we had to make it complicated. It used to be 4 for everybody. Now it's only 4 for electrical injury. It's 3 for children and young children, and for adults it's now 2 cc's per kilo per percent burn. I want to make sure we transmitted that, and that is because people got carried away with the 4, and 4 turned into 6. So 2 is turning into 4 because people don't adjust that. So it's 2 cc's per kilo per percent burn, as opposed to the 4. That is the latest recommendation nationally in the United States. Has it changed in Europe, do you know?
I think so. No.
Do you guys use Parkland or do you use 4 cc's or 2 cc's or a different formula? 2? See, you're smarter than we are.
But we adjust a lot. I mean, it's a very loose recommendation. We adjust a lot on the individual hemodynamic monitoring.
Yeah. So the rule of 9s, how do you estimate a burn? Your palm, including the fingers, is 1% of you. Okay? So you can use the palm method. I usually, on a child, I'll put my hand up to theirs and see how much of their hand is in mine, and I'll just kind of palm it out. Or you can use the rule of 9, where each body part is 9%. The other cheating way, or the AI way, since AI is the thing in this meeting, the SAGES diagram, it's online. You can actually color it in with what you think is the burn size, and it'll generate a number for you. So those are all ways you can do that. And this picture from the British Medical Journal is a really nice one that accentuates the difference between adults and children. Children have really big heads, and it gets smaller when they get to their extremities. Okay, so calculating for Dad. His head is 9, his trunk is 18, 18, 9, 9, for a total of 65. And the child is less because his head is 18%. Okay, and then what fluid would you guys use for resuscitation? Do you use crystalloid? Ringers? Okay, lactated ringers? Anyone use anything else? Anyone use FFP? Or albumin? Yeah, depends. In the United States right now we have 3 randomized trials on resuscitation going. 2 of them are using FFP early in resuscitation, and 1 is looking at albumin infusion early in resuscitation. We tried to get them all together to do it as one, but it didn't quite work out. But colloid is making a comeback, but your lactated ringers is a good initial fluid, and we like to say in burns, we were giving lactated ringers before it became popular again. It's what we've always used in terms of our resuscitation. And then here are the calculations for the child. So you start the fluid. How do you monitor? Urine output? Okay, urine output. Anything else? We're ICU people. We can't just do urine, right? It's too simple. Yeah. I use the kitchen sink. I use everything I got. Although normally we teach urine output exactly, we also use all the hemodynamic monitors. In adults, it's 30 to 50 milliliters of urine an hour. In a child, it's 1 cc per kilo per hour. I like to use also lactate, base deficit, non-invasive monitors, and non-static monitors of cardiac indices. What do you use?
So we use a lot of cardiac output monitoring. So fixed dosing, and depending on the hemodynamic status, it's a patient making urine, lactate don't training, good blood pressure. We don't train on the fluids. The other way around, we up train on the fluid based on cardiac output monitoring and SCVO2.
Okay. Anyone use anything else? Yes, sir. Hematocrit?
Hematocrit, yeah, could be.
Excellent.
A point on urine output is a very good biomarker, but careful. Some patients might have a true acute kidney injury and be oliguric, and in that case, the urine output won't become a good indicator on your fluid resuscitation. So be very careful if you have a patient with oliguric and you keep increasing, giving bodies of fluids, and the urine output should increase rapidly if you increase the fluid rates. Okay, if it doesn't, you should probably switch to another monitoring and think about another cause of acute kidney injury that only hypovolemia. That I would say that would be my takeaway.
Yeah, and the other one is if they get a CT scan with contrast, urine output goes out the window because they will make urine because of the contrast. So you have to be very careful, make sure you keep them hydrated and use other parameters in addition to urine output for that. So I think we're out of time. We didn't get to the wounds. I think some people are glad of that because we have some really great, disgusting pictures. But if anybody ever wants to talk burns or has a question or if they would like any of the references we talked about, we're happy to send it to you. Sir?
Yeah, thank you so much for attending, and we're available for any question, and thank you so much for taking care of burns. Thank you.